Welcome, everybody. I'm Marta Rubiera, a stroke neurologist from the Hospital Vall in Barcelona. I'm very glad to welcome you to this new webinar organized by Trust Stroke, which today is the topic is patient-centered care, how PROMs are improving personalized care. As you may know, Trust Stroke is a multi-center European project funded by the European Union with the aim to validate a reliable prognostic tool based on artificial intelligence to predict and improve the outcome of patients with ischemic stroke. You may probably know the objectives of the project, but globally, we want to establish a trustworthy platform for the based on federated learning network that will ensure the trustworthy and validated IA integrated solutions for stroke risk assessment. And also we want to further develop an app for patient empowerment for stroke patients. And this is the main topic of our talk today. It is my pleasure to introduce you to our two speakers. The first one is Ester Sánchez. She's an occupational therapist and also a case manager from NORA. And then afterwards, it will be the turn of Giorgio Colangelo, who is the CTO of NORA, and both of them will speak us about this app that will help our stroke patients to engage and to take good care of their disease. And with this, I introduce you with Esther. So please, Esther, go ahead.
So I'm going to share my screen. Okay, hello everybody. So as Marta says, I'm going to explain NORA, a new digital tool that facilitates patients follow-up. We will go through these main points. So first of all, to give you a little bit of context, as you know, Hospital Universitari Vall is a tertiary care hospital. We work around 9,000 people and we attend around 1,200,000 people per year. So this is our team, 5 occupational therapists, our coordinator as well is a psychologist, and one of them a physiotherapist. So what exactly is value-based healthcare? Value-based healthcare is a new paradigm of clinical management that in recent years which aims to address aging population of the people, and also the increase of chronic diseases such as stroke. For that, ICHOM, that is a non-profit organization, created standard sets that they involve different standardized questionnaires, and they structure when and how to do the follow-up to these patients. These questionnaires is about quality of life of the person, the pain, fatigue. It's some general information. And this places the patient at the center of the intervention. So the idea is with value-based healthcare is improve PROMs, that is these questionnaires, the patient-reported outcome measures, at the lowest cost possible. So give the best service at the lowest cost. Our role as occupational therapists, I will go through this in a general view. During hospitalization is basically identify the patients, do an initial interview with the family or the patient caregivers. We show how to download the application and give some advice and recommendations to the family and the patients. During the year, post-hospitalization, what we do is there is alarm management. We resolve their doubts. We also send these questionnaires, and there is control of risk factors, the medication. We will go through this more specific in later on in the PowerPoint. And also, we also train new case managers, and we do clinical sessions as this one. So our idea is to establish a supportive relationship with the patients. So basically, NORA and its functionalities. NORA is as you know, it's a panel, a web panel for the professionals, and also has an application for the patients. And as I said, this allows direct contact with them, and in order to solve their questions, their doubts, and also know their needs through the questionnaires. Really fast about all the functionalities. One of them is risk factor control. The patient can add their blood pressure or sugar, and as we can see it here, this is how the patient would see it in the application. And directly, if one of these numbers are alterated, we can see it in our panel here. And then we would have an activation of an alarm, and then we would be able to send a message to the patient, something like, can you take the blood pressure, can you measure it again? Another one is the chat. The patient can speak to us, they can send an image or an audio recording, and it would be the way we would see it. Also, we have the option to do a video call in case we think it's necessary. NORA also allows to send some health information, for example, documents, or like this one that we can see here, or direct videos about the stroke. Another functionality is the diary. We register all the visits they have as a follow-up. We can see it here in our panel as a calendar, and we know when they're going to have their visit, and they have it in the application. And also, as I said, we send some surveys and also PROMs that it would be that patient-reported outcome measures. We think it's really easy because they only have to read the question, click on the option they consider, and just go through this button, and we can see all the answers here. And this is really important for us because it provides us with information about their needs, about we can give some recommendations at home or about their health. Another functionality is, is two actually divided, is they can, if they link it with their email, the Google Fit or Health Kit, they're able to record all the steps they do in the application. They don't have to do anything, they just synchronize it with an email, and then it does all the record, all the register in the application, in the platform. So there is a module of telerehabilitation, and since we are occupational therapists and physiotherapists, we're able to do an evaluation when they're here, or we can do it if we do a video call with them and they think it's necessary. Then we're able to send some activities that we send gradually in order, depending how we're seeing if they're improving or not, with more difficulty and more specific activities. And then we do another evaluation when that study is finished, and that way since sometimes rehabilitation can take a while, it's like a continuous assessment, continuous care while they go back home. Okay, so another option is document management. We usually try for them to sign the informed consent here in the hospital, but if some patients are not able to do it, or they go home, I don't know, at the weekend, then there is this option where they have the informed consent in the application, and it's that easy as put their name and sign it with their finger. And with all that information, what we do is information that we added in the platform, and also information, most of them provided by patient or caregiver. What we do is we generate reports. These reports, we put it in our system so all the medical team can see it, and also the patient and have it in the application. And if they go to primary care doctor, they can show it in their phone. So services that are using NORA, sorry, I couldn't translate that, but is epilepsy, nephrology. We also use it through COVID, cardiology, because it's all other services that are using it here in our hospital, but it's also in other hospitals. For example, with the Project Harmonics, we're using in some referent hospitals here in Catalonia, and also in South America, South Spain, not only with the stroke, but also with, in this case, for example, with diabetic kidney disease patients. So I will stay here a little longer. Our stroke follow-up is when the patient is here in a hospitalization or emergencies, it does all the follow-up here in the hospitalization. When they're gonna go to their home, when they are discharged, the doctors, the neurologists say that to us, and then we would start the follow-up process. The process is during 1 year, and what we do is these days that you can see here is when we send the reported outcome measures. This would be general surveys that we send because we think they're really specific for a stroke. And also we send the patient-reported outcome measures that ICHOM put in the stroke standard sets. And also we send some patient-reported experience measures to know how was the opinion on quality of care, and if we do a visit of the occupational therapy, how they felt about that. After the year, the patient is able to keep the user activate if they think they want to. We won't send any more questionnaires or more health information, but in case they have any question or they want to speak to us directly, they have the option of the chat activated. And here with all the data as well, with all the related data, this is a test, it's not our, it's just, so you can see a little bit. We're able to create visualizing all the aggregated data, so that way we can do benchmarking, we can see the different hospitals, how we're doing, how many patients are included, how many patients use the application or not, if the patient had a recurrence. Would be a general information that is really helpful because it's really visual. And over the years, we had like so much clinical evidence that these are some examples. Or publications in different congresses. And that's it. I don't know if you have any question now or in case you want to leave it for after.
Thank you, Esther. Yes. If I just send it in the chat, if you have any questions, you can write in the questions and answers tool, and if there is no any rushing question now, maybe we can pass to the next speaker, and we can comment at the end of the webinar what if anything that you want. So Giorgio, please go ahead.
Okay, so good morning, everyone. I'm Giorgio Colangelo, and thanks a lot, Esther, for this clear introduction to NORA. So in this talk, I will give rather an data science and analytics approach to data that we collect. If you are here, I think you already know the impact of stroke and how much important it is. In general, 1/4 strokes is a recurrence. So this is a very, stroke recurrence is a very huge thing compared to the overall stroke. And between 16 to 30% of the cases appear within 5 years. And according to recent literature, 90% of stroke recurrences is attributable to modifiable risk factor. So these are basically the three among many factors which motivated to us to develop pre-risk. Marta Rovira, which is moderating this webinar, led this project, which is basically a predictive risk estimation for stroke recurrence. And this is very important. So Truststroke is within in this direction, which is very important for personalized secondary risk prevention strategies. I will give a broad overview on the topic. If you want to find more details, there is a recently published paper in the reference here where you can have all the technical details. This talk is rather general and not going to detail, but very happy to clarify if there is some question. So basically, the base of this study was I would say a huge database. It's almost 42,000 stroke patients observed during an overall period of 6 years almost of 88 public health centers in Catalonia. Of these patients, approximately 6,000 had a stroke recurrence, and this gave us a quite powerful data set for this study. Inclusion-exclusion criteria are basically the standard ones, but in the study also we excluded from the study patients which died within 7 years from the index event. Most of the patients were experiencing ischemic strokes, approximately 32,000, but also we consider intracranial hemorrhages, while we exclude from the patient minor strokes and transient ischemic attacks. Well, in general, the median follow-up, you can see this from this plot. The median follow-up was almost 3 years per patient, which is quite a great observational window. Of course, during this time, we lose some patient, as you can see here in this blue line. And of course, as the observational time increase, we also can observe a recurrent percentage. However, in this study, because we need a cutoff, we cut off to 2 years observation. In general, as you can see in the right plot, patient experienced a recurrent stroke of the same time of the initial stroke. This is true for the 76% of the intracranial hemorrhages, and for 90%, up to 90% from ischemic strokes. This is good information to take into account. Well, the biggest challenge in these observational studies are that in general, we want to know the probability of a stroke recurrence within 1 year from the first event. Of course, what is the problem is that not all the patients have 1 year follow-up. So what happens is that if we have a cutoff here at 1 year, we will have some patient where we have what we call a censored information. So we have two options. Either we throw away all this data, but this would be a lot of data. Otherwise, we have to treat in a special way. And this is the reason why survival analysis, which was developed in the study, take place. So basically, we can distinguish between 3 different patients in this study: recurrent patient within 1 or more, not recurrent patients, and also censored patients, with our patients we have only partial information of less than 1 year. So we adopted 2 different approaches. One is the standard statistical survival analysis, and the other one was the machine learning. Both approaches have pros and cons. I'm not going into detail, but it's good to know that in general, statistical-based models are specifically designed for this kind of problem, have a very strong evidences, and have been used during decades. So they are easy to interpret, and because they are statistically based. On the other hand, they required strong assumption. So this is a bit of the counter side of statistical models. On the other hand, machine learning models, here we consider only 3, but you can extend this broad overview to most of machine learning. In this case, we only consider 3-based or ensemble methods, which are XGBoost, random forest, and DataBoost. They are less interpretable. So from the clinical side, they have some challenge to be interpreted. But the good thing is that they require few assumptions. And when you have complex variables which are intercorrelated with each other and are not statistically independent, they are, let's say, safer to apply. But anyway, we keep these 2 approaches in our study. So what we want to measure? Basically, we want to predict what is the time to recurrence of each patient. And to this challenge, so to this purpose, we associate to each patient data a class of risk, depending of how many days are going to be last to the recurrence. So in this case, we identify a long recurrence risk if there is no recurrence observed within the following year. We have a later recurrence risk if there is a recurrence observed between 3 months and 1 year, and an early recurrence risk if there is a recurrence which is observed within the next following days. And also this is very important differentiation, because once that we determine what is the risk, we can apply secondary prevention strategies, what Esther was mentioning before, to late and early recurrence risk patient. So how our data set would look somehow like this: we have some patient data where we have, for example, some variable which does change in time, for example, the age and sex, but also variable which are changing in time, and we have an entry at several points in time. So we have an initial stroke, then we have data at different days, and then finally we have a recurrence. So on the other hand, we can construct how many days what is the time to event, and then we can associate to each, let's say, data line a recurrent class. And in this way, we can train our models. We do a training which is the standard in this case. We do a cross-fold cross-validation, which means that we have our training data set and we divide it in a test, and this blue part is the training, the data which we use for the training. So because we want to be robust, somehow we repeat this procedure different times, and we apply the test batch at different data set, the different data. And in this way, we can construct several models. We can determine from each model a score, and in this way, we can create somehow a more robust model. So just to summarizing, we have two main trainings. One training of model using all the patient variables, and the other one a reduced model using only clinical relevant variables and modificable variables. Why this? Because somehow so if you are able to reduce the variables only to relevant one, it's very likely that your model is more robust, and also you can give more relevance to modifiable risk factor, which somehow are the variables that we want to attack in the prevention strategies. Okay, so these are the results. So you can see that, so here you have different groups of points for the different classes that we want to estimate. No, so just to have a reference here on this axis is well, of course, the higher the better, and you can see that so here we are measuring a standard metric, which is the AUROC, and basically we are evaluating the performance of the model. And here we have different colors according to the models which we are considering. This yellow, blue, and red are the machine learning models, and the gray one is the statistical survival analysis models. So what we can observe from this plot? So the first thing is that, of course, here we would like to have an AUROC, an area under the curve of 1, but we don't have. We have at maximum 0.6575, which is a good score, but is not a very good score. So in general, the prediction of recurrence is a difficult task, and you can imagine why, because it's difficult because every patient is different, every patient has his own complication. And the most difficult thing is to estimate late, so the middle class, the recurrence which occur between 90 days and 1 year. And here, this is the reason why this is lower here. The second thing is that in general, reduced model, so here you can see in lighter color the reduced model. So as I said before, the reduced model are the models which have less variable, only clinical relevant and modifiable variables. And of course, because they are less variable, we have a less vision, let's say, of the patient. So this is why they perform worse. But as I said, they are a bit more stable, and indeed the error bar is lower. So in general, it's lower, which is it's okay. We expected this, but it's not that much. So this means that with the clinical evidence and modifiable risk factor, we still can make good predictions. No? which maybe was a bit the common sense, no? Well, the third thing is that in general, the gray models, which are the statistical models, perform worse than machine learning models. Perform worse, but not that much. So this means that if you are looking for the best performance, maybe better go for machine learning. But if you are looking for the explicable model, maybe the statistical models can be a good compromise. Well, a good compromise. So other results from these trainings, well, is that we can calculate the risk factors of several variables that we use for the models. No, in this plot you can see several variables that we're using were used for the training, and basically these are all the standard clinical variables that are considered in the literature. So, and you hear basically this is the hazard ratio. The hazard ratio, this means that the risk of which a recurrent patient have with respect to non-recurrent patient. So this means that, for example, chronic kidney diseases patient have a 5% or 6% more probability of having a stroke recurrence with compared to non-kidney chronic kidney disease patient. Same for anemia, atrial fibrillation patient, diabetes, and other things. This is a kind of the standard what we have in the standard literature thing. An interesting finding which we found by the machine learning training was that we found a relevant variable. This is the feature importance in the machine learning training in a PROM, which was the basic daily activity. The basic daily activity, is the, let's say, how much a patient was able to be independent in daily activity. So this is a very good thing, in my point of view, meaning that a Bartel index, which is a PROM, has an important role in the models. The bad thing is that in this data set, we only have, this was the only PROMs which was recollected. So in the vision and envision of TrustStroke, where all these PROMs are going to be collected, it's likely that this prediction can be improved with the other PROMs. So this, I think, is an interesting thing. Also, with the model that we developed, we could create a recurrence probability curve. So here you can see a patient which had a good control of cardiovascular risk factor, the modifiable one, and another patient with a bad control of cardiovascular risk factor. So here you can see that a patient with a good control of cardiovascular risk factor has a 50% less probability of experiencing a stroke recurrence. So this information, we believe, that can be used for secondary prevention strategies and to improve the patient engagement and also to make the patient adopting healthier lifestyles habits. Of course, we have to understand what is the best way to communicate to the patient this information. So just an overview of what's next. So as I said, right now, this prediction are going to be implemented in a clinical study and find if we can improve patient recurrence with more aggressive, using, let's say, somehow some more aggressive secondary prevention strategies. For example, with occupational therapy, with videos, with calls, with healthcare literacy, and so on. The second thing is that this training was made on a Catalan data set with only a few PROMs. So what we are currently working on, but within the Trustrock project and also with the other previous studies is also to incorporate the NORA prompts to improve prediction. And I hope that this with the help of everyone which is working in this project. David Cano, which is a NORA data scientist, is leading this part on our side. And also the challenging thing of applying these models for patient recurrence. So patient recurrence is somehow easier for the statistical and data science perspective because it's easy to say yes or no if a patient record or not. The point is that since the recurrences are 2 or 3% of global patients, you have a very small number, a very small n. So we are developing also with Trustrock and other previous project models to which control the cardiovascular risk factors, the treatment adherence, and of course the recurrence. Because there is evidence in literature that when the patient is more adherent with the treatment, has less risk of having a recurrence, and when a patient can keep on control of vascular risk factor, also has less risk of recurrence. So this is a very broad overview of data science part at NORA and analytics part, and very happy to looking forward and answer your questions.
Thank you, Giorgio. Thank you very much. I can see that for now there are no open questions. Yeah, there is a question here. So it's by Carolina Loser, and she asks that you have so many variables that have impact in the recurrence risk, such as tobacco, cholesterol, alcohol intake. Where do you get them from?
Okay, so these data set, so these data are collected through NORA, can be collected, but this data set was a public healthcare data set of Catalan healthcare system. And Marta, you can give more, I think that more.
Yeah. So yes, this data set came from a public registry of stroke patients in Catalonia. The Catalonia Healthcare has a chronicle medical record of patients, and they have there is an institution within the Catalan network that is called PADRIS, which manage all this data and anonymize them. And if you have a clinical project, then they can allow you access to this anonymized data. So they are basically obtained from hospital discharge reports and also from the scales that are filled by the general practitioners that follow up these patients. So I have another question for you, Giorgio. So you have shown that our prediction, our area under the curve for the predictions are not so good. What do you think that we can improve this? How is the quality of data, more patients? What is your opinion on this?
Well, this is a tough question. So I think that to me it's evident that predict the risk of recurrence is a very difficult task, and maybe there are easier problems, like for example the risk of the treatment adherence, the cardiovascular risk factor, which can be easier to address. I think that there are some data. So, for example, an important thing here is the missing data. We have a lot of missing data. So, better data collection can, of course, improve the data quality and then the model quality. And also, I think that inclusion of PROMs, which, for example, for problems like the treatment adherence, can be very relevant.
Thank you. And there's another question for you too. So, what is the definition of good cardiovascular risk factors control? From Giuseppe Real.
Marta, maybe you want to answer this.
Okay. We actually did an estimation based on the clinical guidelines. Basically, they are captured from the American Heart Association recommendations for stroke patients. So this is one point in the paper that we consider as a limitation in some way, because the guidelines change a long time and our data are from some years ago already. So maybe what before was a good control of cholesterol if the LDL was below 100, and now you cannot consider this a good control. So that's one point, but basically I think that should be obtained from the guideline.
There is also another thing about, for example, in the guideline that you mentioned, there was some variable which we don't have, for example, the diet, the sleeping quality, and so on. These are data which we don't have right now, which can be maybe intelligent to start collecting with Nora from now on. And somehow with all this global variable, we can somehow construct a global risk score as the American Stroke Association guidelines. No, there was this scale. I don't remember the name.
Yeah, the cardiovascular health score or something is called, and this englobes 8 items that and that are considered important for the health, the vascular health of patients. So yeah, I agree that may improve our recollection of vascular risk factors. So while people gets with the questions, I have one for Esther. Esther, can you explain us a bit how many patients you are able to manage by yourself? Because I think people cannot imagine now how you are doing the follow-up of with all this data from patients. So can you explain a bit this?
Yes, so we are 4 case managers, and it's around 1,000 patients a year, more or less. So each case manager does the follow-up of 300 patients.
Okay. And you have a lot of work, I imagine.
Yes, we do.
Okay. And I know you are an occupational therapist, so for the part of the telerehabilitation, your role is very important as this. But do you think another kind of case managers could follow these patients? It's better that this I understand is better that this is a occupational therapist or physiotherapist that can also do the telerehabilitation, but in other cases can be another professional, health professional.
Yes, actually in other services are nurses, where most of them in other services are nurses, or the crucial thing is that they are professional healthcare, and they know about health, and they have learned all of that. because in order to give some answers, there has been maybe some other kind of professionals that are not in the healthcare system, and maybe they cannot provide. They can do the follow-up, but maybe not completely, because there are some questions, some answers that they don't know
Yeah.
how to answer.
I think this is very, very interesting and very relevant because I know you go before the discharge of the patient, you go to speak with them. And do you think this personal relation continues with the follow-up? So it is important that the patients know who they are speaking with by the chat. Do you agree with me?
Yes, I think it's important for them that they can see us, and also they know there is not like a chatbot that they just give the information directly. No, it's not a machine, it's actually a person that is answering the question. And it's also good for us because we get the chance to meet them and know a little bit about them, and we can give some recommendations while we're in the room. And also I think that is good for their adherence in the platform.
Okay, thank you. And another question. So this is for both of you. Do you think we should show our patients the risk? So as Giorgio showed in his presentation, we have these curves where we can estimate more or less this patient has a high risk, a low risk. And so can we show them that they are at high risk of a stroke and they will be scared, or it will improve their adherence? What is your opinion on that?
Well, I think this is a very open question. Here, there are a lot of clinicians, C connected. There are UX designers. So I think that this should be a very complex and it's a complex study, and we have to understand it. Right now, I don't have a question. So first of all, because I'm not a stroke patient, I don't know stroke patients, so I'm not the person to answer this, but I think that this should be a collective answer. But I see also patient stroke association representative, patients connected, so maybe they have to answer this.
Okay. I don't know if they can answer actually. I don't know if they can speak. But if any of you want to share your opinion on this, we have the chat and we can read it. Or I would like to know the opinion of patients. That would be very interesting. And I think this is one of the things that we are doing in Trust Stroke, to try to also improve NORA for improving the patient's experience. Is that right?
I think it's important that they know there is a risk and how important it is that their health and take care of that. But I think we also have to be careful because they just had a stroke, and to know the risk of having another one depends how that information is given. They could stress them, or maybe make them not feel really good about it.
Okay, thank you. Thank you. Yeah, I agree. I agree with that. This is a tough question for all of us, but you can see the adherence of stroke patients after for the medications decrease dramatically after some months. So this is one thing that we need to improve. What else? Any more questions for the audience? Somebody wants to participate? No. Well, another question for Giorgio. So what do you think we should predict? What else should we predict on those patients?
I think the crosstalk already fixed the clinical endpoints. So when patient, for example, about physical disability, work inability, and as we said, also the risk factors and the control of risk factors, and what, you know, these things.
Okay. Okay. So I think if there are no more questions from the audience, I would like to thank both the speakers for this very interesting webinar, and I hope all of you have enjoyed as us, and we learn a lot of things with these webinars, and I hope to see you in the next webinar. So thank you very much.